I want to take a moment to thank Allah Subhanahu wa Ta'ala for all the blessing He has given us. We are truly grateful for the gift of both physical and spiritual health, which allows us together here together for the ablation therapy as an alternative in the management of liver malignancy. I want to take a moment to sincerely thank all the directors of Fatmawati Hospital, as well as the attendants and colleagues who made the effort to join us for this ablation therapy as an alternative in the management of liver malignancy. As the chairman of KSM, I want to sincerely apologize for any shortcomings or anything we have found objectionable during this event. Intinya perkembangan teknologi kedokteran terutama di bagian bedah terus berkembang ya, seperti minimal invasive surgery, kemudian robotic surgery, intervensi, paradigma operasi yang merupakan suatu yang menakutkan, menyakitkan buat pasien, harusnya sudah berubah ya menjadi sesuatu yang aman dan nyaman dengan nyeri pasca operasi yang minimal dan lama rawat yang singkat tentunya. Jargon seperti big operation with big incision mungkin udah kita nggak gunakan lagi ya, mungkin kita ubah dengan big surgeon with small incision or big surgeon with small puncture, I think. Untuk itu mungkin kita hadir di sini penting ya untuk sama-sama belajar dari para expert ya dari luar, thanks to special guest speaker Dr. Beth from Malaysia. Thank you for coming to our hospital, dan para pembicara dari Rumah Sakit Fatmawati sendiri. Mudah-mudahan acara ini bisa bermanfaat buat kita, dan yang paling penting bisa kita aplikasikan di rumah sakit ini semata-mata untuk kebaikan pasien-pasien kita yang kita tangani. Terima kasih atas perhatiannya. Wassalamualaikum warahmatullahi wabarakatuh. Terima kasih Dr. Mursyid atas sambutannya. Untuk selanjutnya kita sambut Dr. Muhammad Taufik, Asari Taufik, spesialis anestesi KIC selaku Direktur Produk dan Keperawatan. Silakan Dr. Taufik. Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. Good morning, Prof. Bati Reddy. Am I right? Spelling your name? Okay. And also, good morning for Mr. Robedio, yeah, the CEO of the RF Medical Corp. And good morning, everyone, ladies and gentlemen. Welcome to the workshop of Alternatif from liver cancer. Me, on behalf of the director of Fatmawati General Hospital, would like to congratulate to Dr. Adi and Dr. Nico, Dr. Aijo, and all of the committee to make this workshop happen. And of course, this is really important treatment for cancer, especially for liver cancer. We have a lot of numbers with the patient who has a liver cancer from the hepatitis,
and then going to the liver cancer. So this is really important treatment. But Dr. Bad, we already speak about the another option, not only for liver cancer, but the RF would be useful also for another cancer, lung cancer, and then thyroid cancer, and also what else? The OBGYN cancer, is it a myeloma? Is yes, yeah. So I think RF is really important for Fatmawati Hospital to have probably next year. Hopefully next year we want to buy this machine. Me as a medical director will push to hospital to buy the machine. Uh, yeah, because a lot of people need this treatment. And as we know that hopefully this year, Fatmawati Hospital will increase the services about the liver cancer to hopefully for the liver transplant. You also mentioned about this RF would be useful before the liver transplant who has a hepatocellular carcinoma. And then, yeah, I think this is really important workshop for today. And all of the participants, I hope, will absorb a lot of knowledge, a lot of experience from Dr. Bhatt, who has, you said that 1,000 per year about the cases ablation. Okay. Wow, you have a lot of numbers, and hopefully we will get all of your experience about the ablation uh, radio frequency and radio frequency. Micro radio frequency. Micro vessels. Okay, there's another things. Okay. Oh, wow. Okay. So you will share your experience, all of your experience here, and all of the doctor will uh, absorb your experience and your knowledge. We have a surgeon here with related to diagnostic surgeon here. There is endocrinologist. So I think when we're talking about cancer, it's a multidisciplinary team and multidisciplinary treatment. So today, I'm very happy on behalf of the director of this hospital. It shows that our hospital it's ready to make a comprehensive treatment for cancer. I think that's all for today with Bismillahirrahmanirrahim. Uh, Today's workshop of ablation therapy as an option for managing liver cancer is open. Thank you.
Terima kasih atas kata sambutan dan pembukaannya, Dokter Muhammad Asari Taufik. Untuk acara selanjutnya, supaya kita meninggalkan kenangan terhadap acara ini, maka berikutnya kita akan adakan foto bersama terlebih dahulu. Silakan. Silakan para peserta bisa ke depan. We would like to take a photo. Baik, kita sekarang ke acara intinya. Untuk acara intinya akan dipandu oleh moderator Dr. Adianto, yang spesialis bedah, subspesialis bedah digestif konsultan, sebagai moderator sekaligus juga sebagai speaker. Itu waktu dan tempat saya serahkan ke Dr. Adianto. Silakan Dr. Adianto.
Terima kasih Dr. Gana. Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi, salam sejahtera untuk kita sekalian. First of all, thank you to our beloved director, Dr. Taufik, for opening this occasion, and also for Dr. Mursid to give a speech. And I would like to say thank you to my friend, Professor Iridui, for sharing with us today, and also for Bu Monik and team for making this happen. We will have a discussion today on ablation therapy, especially for liver cancers and also for other type of disease. I will start with my presentation first, and then Professor Iridui will do the presentation, and we will have case discussions, and hopefully this will be a fruitful discussion to all of us. My slide, please. And also, thank you for the participant in the Zoom, my friend from Digestive Surgeons from all over Indonesia. Thank you for joining us. Okay, this would be just a short introduction on surgery for liver cancer, a general perspective. Slide, please. Bisa ya pakai ini, bisa? Okay. So if we're talking about liver mass, then we will be talking about benign disease and also a malignant one. As for the malignant cases, we often encounter HCC in our daily practice, as well as cholangiocarcinoma and liver metastasis from various organs. And talking about HCC, it's a very much fourth malignancy in Indonesia, because we are endemic with HBV. We have endemicity of the HBV. That's why our number of HCC is increasing, and a multidisciplinary approach is very much important to have a better result. Talking about HCC, usually we are always rely on the BCLC. This is the Barcelona Clinic of Liver Cancer Staging, where resections play an important role. But in this staging system, sometimes we are not suitable in Indonesia, because the size of cancers is usually small. But the one we had in Indonesia is a much larger tumor. So we have a consensus on the HCC from Indonesia. We can see here that we can have a nodule of more than 3 cm. And resections is still the number one treatment options for this kind of cancers, together with TACE and ablation. We will hear more about TACE and ablation from Professor Iridui in the next session. And talking about liver cancer, this is a very old paper from 2011. For malignant tumors of the liver, the oncologic resections is the number one choice. And for primary liver cancer, thank you, Dr. Taufik. For primary liver cancer, as HCC, we usually recommend an anatomical resection, and for the secondary liver malignancy, we can do non-anatomic resections. For liver resections, it's very much depends on the liver volume. So where we have good liver volume, then we can be confident to have a safe resection. But also we have to take care of the other factors, including Child-Pugh score, the portal hypertension, the anatomical variations, and biliary drainages. So it's not just factors of the volume, but other factors as well. Again, this is from the 2011 journals. We can see here that anatomical resections is reserved for the HCC and cholangiocarcinoma, where other cases we can do more minor resections. But regional lymph node dissections is mandatory for intrahepatic cholangiocarcinoma and hilar cholangiocarcinoma. Okay, so this is where resections plays a more important role, because as we know in HCC, it's a very arterialized tumor, where the tumor itself spread from the mostly with the high flow of artery. Therefore, sometimes the hepatic vein is a little bit constrict, and there are possibility of having intrahepatic metastasis because of the flow from the artery is going not to the hepatic vein, but back to the liver. As we can see here, we have the arterioportal fistula, where in this case, when we do anatomical resections, we remove all the parts of the liver with that portal flow. We can have a more safety in oncologic side, where other modalities such as ablation in a much larger tumor sometimes cannot achieve this. Okay, this is the example. If we can do a anatomic resection, let's say here we can resect the portal 8, then the whole area that have from the portal vein 8 is removed like this, and the surrounding area is still alive. Where if we can just do a non-anatomical resection, we can suffer from something, some area of devascularized, and this area can make other problems later. Okay, this is from recent journals. In 2024, we can see for a smaller tumor, there's a similar result, either for surgery or ablation. But for a bigger one, I think this study shows that surgery has a better outcome. In fact, in Indonesia, we have to deal with this kind of tumors, very large and sometimes late in disease progression. And we have a lot of challenge where sometimes we have to see this kind of image instead of having this kind of image. Here in Fatmawati, we are very fortunate to have a good radiologist and good radiologic system to be able to have this kind of image. But if this patient is referred from other hospital, then this is what we have. So it's very difficult to plan for the surgery with this kind of image. Okay, this is just to remind us that doing a liver resection, we have to deal with the inflow as well as the outflow. We can do a lot of resections, like this one is segment 2 and 3 tumor. We can do a left lateral sectionectomy, and also this is a simultaneous surgery where we removed altogether the kidney as well as the liver metastasis altogether in the same operation. This is a case where my colleague here, Dr. Asri, was doing hepatic resection for a large hepatoblastoma, as we reported, only with a very delicate instrument, a clamp crossing techniques, because at that time we don't have any CUSA or other thing, and thankfully these patients also recover very well. Again, I would like to remind that after this, Professor Iridui and also Bu Monique will tell us a lot of ablation therapy for liver cancer and all the other. I found this just recent a while ago, that we actually, in the case of a very large tumor or a multilobar tumor, we can do multimodality. Instead of just doing resections, we can do together with the microwave or together with the RF ablation to achieve a better survival and a better outcome for the patients. Here's some example from China, where a combination of hepatic resection together with RF will provide more chance of survival in a bilobar cancer. So again, I would like to remember because safety is always our most important factors that we have to remember. And in liver resection, it is no bleeding, no biliary leakage, and no necrosis to achieve toward a zero mortality. So hopefully we can achieve this together with lots of modality. And okay, and this is just something that we all have to remember, that the ultimate goal is not a good death, but a good life. So a quality of life is very important. That's why if we can do a minimal but multimodal therapy, including the use of many ablation technology, we can have a better quality for the patients. Thank you very much. And I was use this slide, Professor Iridui, in my presentation because all of our work cannot be done alone. So all together, we have here our interventional radiologists, intensivists, nephrologists, and everyone working together. And we can see here's my scrub nurse. Is very skillful scrub nurse, making our operations shorter and safer. Thank you very much. And now for the most important presentation, I would like to invite Professor Iridui to come and case.
So thank you so much, Dr. Adianto Nugroho. As we met before in Korea several times, and I'm so happy to be here. Thank you for doctors who are interesting the new thermal ablation method and technology. So based on your director and also Dr. Adrianto's presentation and speech, you guys, I think, ready to accept that technology because of you guys have good surgeons who can perform hepatectomy and digestive surgeons and also IR doctors. And it's, I think your team can work like this kind of field. So let me start my PPT, and it's going to be more emphasized about a new technique, microwave ablation system. And I have more than 1,000 case experience, which performed thermal ablation for liver cancer and lung cancer. And today I will talk more emphasize about liver cancer treatment with microwave system. So as we know, this microwave system is become a more famous and popular in many countries because of several advantages to compare RF ablation. So my today's topic's content is I will talk about tumor stages, as Dr. Adrianto mentioned it, and also what is the treatment option, like a thermal ablation, what is RF and microwave ablation, and several benefits, and also who can perform that kind of cases, and indication and contraindication, and how to perform the liver microwave ablation, and some treatment protocol, and post procedure monitoring, and a follow-up, and complications, and last message I will mention. So the Dr. Nugroho is mentioned about the Barcelona criteria. It's an updated version, as it can be more easy to understand. You guys can see here that liver resection and ablation and ablation, transplantation, resection, they are actually can be like a curative treatment options. They belongs to the like R0 or like a full curative treatment. But we need to think one thing. Important thing is this tumor size and number of the tumor. If tumor is bigger than 4 centimeter and more than 4, and also some extrahepatic metastasis, maybe we will not select those treatment options. Only these two commonly can be like a radical treatment option. And also we can perform like combining with transarterial chemoembolization and add liver ablation can be curative too. So please remind this updated BCLC staging system, and still ablation treatment is still reliable in the BCLC criteria. So what is the difference between radiofrequency ablation and microwave system? The radiofrequency ablation is using ionic agitation, like a plus minus ions movement. And we're calling the ionic agitation, and to sync to producing radio frequencies such as around 450 to 500 megahertz, kilohertz, like waves. So this is a radio frequency ablation. What about the microwave? The microwave is similar like our oven we are using to heating our food and other things. Same thing, it can rotate water molecules, and our water molecules pulse rotating and really fastly changing, and to make heat surrounding antenna. It's using like a 400 till 205,500 megahertz. This is a difference in physical difference to modality. So as we know, this is really minimally invasive, just ultrasound or CT guidance puncture to the liver cancer and to make ablation. There's no any big scar and not required longer general anesthesia. It can be a much faster procedure and also less expensive. You can see from here benefits. First, less invasive and not using a grounding pad. As RF ablation is using a grounding pad, but microwave is not used. And safer in patients' cardiac devices such as pacemaker or stenting. That's more safer. And rapid heating and cooling. Actually, much faster ablating. And larger ablation zone can be reach shorter ablation time. And also applicability. And the benefits also effective tumor control rate is especially for the primary and metastatic liver cancer, and both of them we can use it. So, and also that especially periportal ACC, which can say like a heat sink effect sensitive lesion, which located near the big vessel and also near the bile duct, that can be complete ablation without any heat sink effect. And also the subcapsular tumors, we can use this machine with other techniques such as hydrodissection and artificial ascites. And evident lock operation rate, overall survival rate is higher, and improved quality of life, short recovery time, a low complication rate, and less postoperative pain and scarring, and flexibility in the treatment. Those are benefits of this. So many countries, and especially Japanese doctors, hepatologists, they are doing microwave and RF ablation as well. In my country, most of our doctors doing this procedure, interventional radiologists, and also hepatobiliary surgeons and hepatologists, they do. And you guys have digestive surgeon, maybe you guys can perform this kind of procedure as well. So the indication is really important. The main topic of this indication is size and number of the tumor and also location. So we don't select like a bigger lesion, like a more than 4 centimeter. In case of we select like 4 or 5 centimeter lesion, we can perform with combining with TAs or using 2 needle or 2 puncture, something like that. So, liver metastasis, colorectal cancer, and all the gastrointestinal metastasis and cholangiocellular carcinoma can be treated by microwave ablation as well. And multiple HCC, also metastatic cancer, can also ablate several times. Maybe we can ablate in this month 1 or 2 lesions, and a few months later, again ablate another lesion, like a sequentially. Not every tumor once can be make an interval, like a few days. So, and the child pre-class low grade B, so that in case of little bit ascites, we can treat after anti-ascites diuretic treatment. So important things is we need to be carefully liver function as well. If liver function and a coagulopathy is make a problem, we need to be careful. That's the one is we talk about ascites. First, we need to cure ascites. If this is untreated, like untreated ascites, like a refractory ascites we did, this is we don't. So also I mentioned it, the bridge transplantation, downstaging net score, and if the patient reject or like have some anesthesiological contraindication for the surgical resection, we can make ablation, and also can also palliative propose some kind of pain or like aggressive, painful, or high risk to become more bigger, like this kind of things. So also the pacemaker who have a patient who have pacemaker and also implanted defibrillator, we can use it. So the contraindication is we need to consider about like coagulopathy, because of we will insert the antenna into the liver percutaneously, and after ablation we need to think about the track ablation as well. But if the patient have too much the problem with coagulopathy, we will not do this. And several liver dysfunction, such as liver failure and liver dysfunction, and also extensive tumor burden, and also the important structures such as bile duct and other blood vessels. So, and extrahepatic disease, and also more than 5 number of the nodules, and the late stage of child pre-classification, and trombin time is less than 30, more than 30, and trombin is PLT is less than like 80, 40. It's really to be careful. And the patients with HCC colorectal cancer metastasis closer than 1 centimeter to the critical organs such as stomach, gallbladder, and biliary structure, and diaphragm, and bowel. In this case, we need to be careful. But we have some techniques to use, like hydrodissection and artificial ascites and artificial pneumothorax. So those are devices. Maybe after the presentation, you guys will see, and I will show you and explain more. So the preparation, the treatment protocol is important, and the many doctors ask, should we use general anesthesia or local anesthesia? It's up to you. From the beginning, it's local anesthesia is helpful because of the patient can help us to holding a breath and deep breathing, and to helping to make a targeting. That's why when you guys starting, make maybe local anesthesia, and under the ultrasound guidance, you make a puncture at the time patient can be help you. And when you start your ablation, maybe you guys can give some small sedation, like a propofol or vascular sedation. That's my goal. And the patient mostly lay down like a spine position. And of course, we need to make a local anesthesia and also disinfect near the puncture site, and then ultrasound probe must be covered like a sterile cover, and then ultrasound guidance and local anesthesia, and then insert antenna under the ultrasound guidance. So the ultrasound imaging is really important during the ablation as well, because of once we start ablation, we will control the under ultrasound, and also our machine will telling us the watts. So how to insert the microwave antenna, there's a really important thing is central location. If you want to make only one puncture in one ablation, maybe like a smaller cancer, like 3.5, 3 centimeter lesion, you guys can make only central located puncture and then ablate. If you ablate like a 4, 5 centimeter lesion, maybe you can ablate like a 60% and another 60%, like 40% can make ablation. And ablation needle can be ablate further like 0.5 centimeter. That's why you don't need to penetrate that a tumor, just you can touch the proximal and distal border of the tumor. And this is a technique. And also we need to think about safety margin, because of tumor has some small satellite tumors near the main cancer. That's why regarding malignancy, we have to consider about safety margin ablation. So the important thing is the ablation technique is really good designed on this machine. Before, my experience is I used radiofrequency ablation, and this ablation method can be make some tumor seeding. And tumor seeding means too much ablation or too sudden ablation can make some hot air bubbles came out from the tumor capsule, and it can make some invasion to the small vessels such as portal branch and hepatic veins. It can make some thrombosis, and this is designed by like a multiple step mode, can increase watts small by small. This can be prevent like this kind of potential risky. As far as I my 10 cases for the liver cancer and 10 cases for the lung cancer, I like to use that modality. So the ablation is once started, ultrasound shows us color changes. Tumor was like a normal color, and during the ablation, and color can be changed till white. So on the other hand, I will explain okay. So the recovery and monitoring is during the ablation, we need to keep observing in the ultrasound machine, and ultrasound telling us how we are complete or how we are incomplete ablating. And once you realize you think this is complete ablated, you can finish your procedure. If you think some part of the lesion is incomplete ablated, you can change the needle angle and repeat ablation. And after the ablation, we need two monitoring. One is image, like a radiological imaging, ultrasound and contrast enhanced CT scan, and this one. And on the other hand, laboratorical, we will check alpha beta protein and PIVCA2 as well. If before ablation and after ablation, after ablation, alpha beta protein must be decreased. So the contrast enhanced CT scan must be give standard follow-up protocol. So that right after the procedure, most of the patients have no pain. Only during the ablation, they are feeling a pain, and after ablation is the same time stop the pain, most of the case. And after ablation, we can give the patient some antibiotics to prevent some infection or abscess formation. The observation period is in the one hospital is a few hours or one overnight, and then after then we can follow up the patients. It's up to you. If you think the procedure is done by very safety, as you don't need to worry about more 24 hours. So the patient can be suffer like a small amount of bleeding, vomiting and pain, but it's not so big problem. It's the big problem is neighbor organ burn or like a bleeding and or some big damage for the gallbladder and other vessel or diaphragm as well. So the follow-up, it's we make this like early and late, and every 3 to 6 months, and we can control as a for the controlling is a contrast enhanced CT scan is really important. If after 2 or 3 months the contrast enhanced CT scan not giving any big change, you guys can delay that follow-up as well. So the complication. So we have to be increased in our practice, our experience, and otherwise we will fail or we will feel and experience some complications. So that minor complication is during the procedure, patient can be feel pain and also a little vomiting, and it can be skin burn. Pre-procedural, it's fever and asymptomatic pleural effusion, and arterial portal shunt can be, and the gallbladder wall temporary can be like edema. It's can be also, and in delayed, the minor complication is can be a stenosis of the biliary tree, bile duct. The major complication is during the procedure, it can be like a hemorrhage, and hemorrhage. This is a big issue. And a peri-procedural is a perforation of colon and pleural effusion, and after procedure can be like a liver abscess. And delayed is like empyema, bile duct injury, and biloma. And another one is tumor seeding. That's the one of the big issue. So that's the general anesthesia or like a local anesthesia is up to you. It's but you guys can be start like a general anesthesia, and always we need to evaluate and to measure the and good planning our strategy to ablation size. We don't need to select like a too big lesion or too small lesion. It's not easy to make a target. That's why it's really approximately size tumor is maybe 3 centimeters. Okay, when you begin, they start the microablation. So the microablation needle, the antenna is really clear, visible on ultrasound. That's why I suggest you please make a ultrasound guidance to perform the microablation. And also it's made by stainless steel. It's not fiber material. The material is good, sharp enough, can insert straight, and you guys can reject the location. That's the one of the advantage. And please be ready if they have some serious complications, such as pneumothorax, or such as bleeding, or such as some biliary duct injury. And you guys have surgical team. That's why it's, but it's really rare. Don't be afraid to be like a bigger, like this kind of complication. So please avoid to make a puncture to the biggest portal branch. On the way, your puncture, it can be like cross some portal branches, but you need to avoid that portal branch. And during the ablation, please monitoring the blood pressure, saturation, and also all the time monitoring and ultrasound as well. So that's my take-home message. So this is how look like in the CT guidance. The segment 7 and lesion is punctured by antenna and the CT guidance you can see. So here is the small short video. Can you play the video? The video. Just playing a video. this how it rotated. It's rotated. So this is one patient has full cancer ablated by microwave ablation, and after ablation, how they look like. How important contrast intensity CT scan. You can see that the ablation zone, it's here, and can you go? Huh? And the multiple ablated the lesion in here, and here, and here, and here too. The full lesion is ablated by microwave system, and after 1 year, it's still no any recurrence. So the follow-up is like this. So this is a one patient performed in our hospital last year, and so that ultrasound guided puncture is insert a needle that the ultrasound controlling. You can see here the kidney. Here is the liver, right? The liver, and then insert your needle antenna under control ultrasound, and after ablation, your tumor will be look like this, whiter, becomes because of the hot air bubbles. So as I would like to mention about this hot air bubble as a popping phenomenon is not nice. If you make like a sudden higher watt, faster ablation with higher watt, it can be like this hot air bubble as a popping phenomenon will be happen. And how to prevent this one? Please use like a multi-step mode and to increase your watts like slowly. And then you will feel free, like without feel like you will make a perform without this popping phenomenon ablation. Can you go this video, the play video? Not play, okay. Oh, really? It's going. Okay, now playing. Oh, yes. So that during the ablation, we can control the how we are ablating, okay? And when we remove the needle, also we can make it some crack ablation as well. So thank you, terima kasih. And due to time limitation, I will finish. So please ask and let's make a discussion together. Okay. Yeah, we have a discussion.
Thank you for the wonderful lectures as always. So now we will have Bu Monik to give. Kita lihat Bu Monika akan cerita tentang penggunaan microwave di Indonesia selama beberapa tahun terakhir. Silakan Bu.
Assalamualaikum warahmatullahi wabarakatuh. Terima kasih kesempatannya untuk siang hari ini. Perkenalkan saya dengan nama Monika. Saya dari RF Medical, kami sudah 10 tahun di Indonesia. Kami yang memulai di berbagai bidang selama 10 tahun. Jadi kami sudah experience selama 10 tahun, waktu itu hanya ada Medtronic untuk HEPAR. Dan RSCM meminta kami untuk supply satu alat yang bisa efisien. Nah, kelebihan alat kami adalah satu generator bisa memiliki 11 aplikasi dengan harga di bawah 1 M. Dan itu membuat berbagai manajemen rumah sakit menjadi sangat interest. Karena return of investment hanya dalam hitungan 1 tahun itu akan semuanya akan break even. Dan kalau kita mengikuti INASI BIJIS 2021, banyak tindakan yang sudah masuk dalam cover inasi bijis. Cuman memang BPJS klaim masih lebih terlambat. Next. Aplikasinya adalah seperti ini. Jadi kita memulai dengan lever. Tetapi lever selama 10 tahun usernya 8 orang. Setelah 10 tahun juga masih 8 orang. Jadi Medtronic sudah almost quit dari pasar ya. Karena kita benar-benar sangat sulit untuk survive. Ternyata apa yang terjadi di Indonesia, kenapa HCC tidak tertangani dengan RFA dengan baik? Nah, kita akan melihat dalam slide selanjutnya. Sebaliknya, aplikasi yang lain berkembang dengan luar biasa pesat, seperti thyroid. Kami ada 50 generator, belum seluruh Hermina, Primaya, semuanya tertarik untuk mengembangkan thyroid. Dan hemoroid itu juga amazing, melebihi superior dibanding laser. Varicose vein, 3 bulan yang lalu saya pernah presentasi di KSM Bedah dengan Dr. Mursid waktu itu dan Dr. Enos. Seluruh bedah kita pernah ketemu karena varicose vein kita di Eropa 100.000 kateter per tahun. Jadi kami berharap satu saat kita bisa trial di rumah sakit ini. Selain itu untuk mioma adenomyosis, kalau orang awam kita tawarkan tidak perlu lagi histerektomi, tidak perlu myomektomi, dan tetap bisa fertilitas, itu sambutan masyarakat, wow, luar biasa sekali. Dan itu semua berkembang dengan baik. Tetapi menjadi satu pertanyaan kita sebenarnya, alat ini sangat bagus untuk lever. Tetapi kenapa HCC menjadi sangat sulit di Indonesia? Jadi generator kami masih ada sekitar 6-7 generator lagi yang kita proses sampai dengan akhir tahun. Jadi kita hampir merata di Jawa, Sumatera cukup banyak, Kalimantan baru ada 2, Sulawesi ada 2, yang area yang lain masih berkembang. Nah, indikasi yang kami pakai selama 10 tahun, kalau kita hitung liver, itu 400 pasien selama 10 tahun, berarti setiap tahun hanya 40. Kalau dibagi tiap bulan berarti cuma 3-4 case. Dan itu sangat jauh dibandingkan dengan thyroid 2.600. Varicose vein sangat banyak, myoma dan lain-lain semuanya berkembang dengan baik. Dan bagaimana dengan di dunia? Kalau kita lihat di dunia, tren berdasarkan paper, RFA adalah penelitian terbanyak dengan lebih dari 500 paper per tahun. Dan terbanyak adalah untuk organ liver. Jadi sebenarnya RFA ini untuk liver penelitiannya sangat banyak. Warna ini menunjukkan, warna merah menunjukkan penelitian di atas 1000 artikel. Dan di sini China, Jepang, Korea, Eropa itu sangat mendominasi. Dan yang biru adalah dari 1 sampai 199 paper yang pernah dikeluarkan tiap negara. Kalau kita lihat lebih detailnya, Indonesia hanya 0,07 paper. China 45%. South Korea 12%. Jadi ini adalah untuk negara Asia. Dan Indonesia dibanding Filipina, dibanding Vietnam, Thailand, Singapura, Malaysia, Indonesia menjadi yang terbelakang. Paper ini adalah paper 2019. Dan kalau kita lihat lebih maju lagi, kita akan melihat Indonesia lebih tertinggal dan lebih tertinggal lagi. Ini satu paper yang dikeluarkan oleh Profesor Rino bersama Dr. Rinaldi, Dr. Irsan Hasan, Dr. Agus Waspodo, berarti Dr. Liandra, berarti Darmais, RSCM kerjasama. Kita akan lihat mereka mencoba memilah dari 151 pasien. Dari 151 pasien ditemukan ternyata ukuran yang kurang dari 5 cm hanya 4%. Antara 5 sampai 10 mayoritas 64 atau 42%. Lebih dari 10 cm yang paling besarnya ada di angka 23%. Jadi otomatis treatment yang bisa dilakukan hanya TACE bersama dengan sistemik terapi. Dan ini di Indonesia dijalankan menjadi mayoritas 35% dan 20% sekian. Tetapi kita sangat sadar kalau sebenarnya reseksi itu adalah the best. Di sini data yang dikemukakan oleh Prof. Rino adalah 60% reseksi compare ke TC kombinasi dengan sistemik terapi. Sedangkan RFA kita bisa lihat di sini angkanya hanya 3 pasien. Tetapi yang mengejutkan ternyata reseksi juga hanya 11 pasien. Berarti semuanya adalah dengan sistemik. Otomatis kalau kita melihat kembali ke BCLC, berarti RFA hampir tidak bisa dilakukan di Indonesia. Karena RFA bisa dilakukan di bawah 3 cm. Sedangkan pasien hampir tidak ada yang sedikit sekali yang di bawah 3 cm. Otomatis mereka akan lari ke systemic treatment. Tetapi satu hal yang menarik di dunia saat ini adalah dari akta yang kemarin hadir, kita akan lihat penemuan di dunia. Jadi worldwide mengadakan kombinasi antara lenvatinib bersama dengan thermal ablation. Dan ini akan membuat pasien dengan ukuran 5 cm, kita bisa kecilkan dulu imunoterapi, habis itu kita ablasi. Dan Profesor Dayana Payawal dari Philippines menyampaikan kalau itu memang proof concept untuk immune modulation of ablation. Dan kalau kita lihat di dalam Google Scholar, berapa jumlah penelitian yang berjalan adalah 2.600 untuk kombinasi antara thermal ablasi plus lenvatinib, 2.600. Kalau kita lihat setelah 2020, 2.100 paper. Berarti kami mengajak, mari Fatmawati, kita bisa bersama-sama trial, kita bisa bersama-sama untuk memikirkan pengembangan ke arah lebih depan. Dan khusus untuk microwave, kita tahun ini launching microwave. Kelebihan kita microwave yang paling utama itu, kalau ibu-ibu terutama tahu kalau kita masak atau panasin di microwave, kita tidak boleh menggunakan besi. Mungkin kita semua aware ya, kita harus menggunakan plastik, jangan menggunakan besi karena tidak boleh besi masuk dalam microwave. Tetapi itu menjadi satu masalah pada saat kita menggunakan untuk menusuk ke lever ablasi. Karena akibatnya mereka, kompetitor kami menggunakan fiberglass. Dan di Indonesia sudah ada satu rumah sakit yang tadi kita bicara sebelum acara ini, mereka menggunakan fiberglass, tapi kami menggunakan stainless. Nah, apa yang terjadi kalau bedanya apa? Nah, kita bicara adalah sespherical mungkin. Sespherical mungkin itu berarti adalah target atau dream atau yang kita harapkan. Dan kalau kita katakan kita mau mencapai 3 cm plus 1 safety margin, berarti ini 3 cm dan ada safety margin. Dan alat kami bisa membuat sespherical mungkin. Sedangkan kita tahu kompetitor ini ada di Indonesia, yang nomor 2 juga ada di Indonesia. Kalau kita lihat yang ada saat ini, sphericalnya tidak tercapai karena mereka menggunakan stainless steel. Sedangkan di sini adalah oscillating gelombang, itu tidak bisa dengan stainless steel. Jadi mereka akibatnya menggunakan stainless steel tapi tidak bisa spheric. Yang kedua adalah bisa spherical, bisa melingkar, tapi mereka menggunakan fiber. Jadi kami mengembangkan satu-satunya antena stainless steel dan bisa spherical. Yang kedua adalah masalah popping. Jadi ada satu istilah yang cukup terkenal yaitu popping adalah kalau terjadi seperti gas blub gitu ya. Kalau ini ditemukan bahwa lenfatinib ternyata ada diduga bisa menyebabkan popping. Nah, kita akan coba tunjukkan dengan video popping itu seperti apa dan itu sebenarnya kehebatan microwave juga, tapi akan menimbulkan side effect seperti popping. Tolong video. Nah, ini dokter, microwave cara kerjanya langsung push. Tapi push di situ kalau terjadi pop akan kemungkinan spreading. Dari ke slide saya, kita harus menghindari adanya popping. Kami menggunakan satu pendekatan yaitu multimode. Jadi powernya kita naikkan pelan-pelan supaya tidak terjadi push. Jadi pelan-pelan dan target tercapai di sini. Karena akan bermunculan ke depan penelitian-penelitian tentang popping. Baik, itu presentasi kami dan kami selalu hadir dengan hands-on tiroid dengan Dr. Harley dan tadi saya ngobrol dengan Dr. Iksan. Untuk Dr. Mursid mungkin di sini bisa menjadi center se-Indonesia untuk RFA karena closure fast juga tidak seambisius kami, tidak seaktif kami. Jadi kami berharap RFA bisa varicose vein, bisa di Fatmawati, mioma, low back pain, Gatam Institute dan lain-lain kita semua bisa kembangkan dengan Fatmawati dan kita berharap terutama Dr. Adianto, maka spesial hari ini kita membicarakan dengan topik hepatoselular karsinoma. Baik, terima kasih waktunya.
Thank you for terima kasih Bu Monik. So after this we will have the discussion. So I would like to invite Professor Eri Dwi, Dr. Adrisel, and Dr. Nico to come forward and sit in the front. And we will discuss the first case. So for the first case, Dr. Nico will present and then we will have the discussion after the first case.
Thank you for the great opportunity to share our case here. I want to share our case in Fatmawati. This is the case of male 70 years old from Jakarta. He complains about abdominal discomfort since 3 months before admissions. Since 3 months before admissions, he complains about abdominal enlargements and then abdominal discomfort and also right upper abdominal pain. Right upper abdominal pain with sharp characteristics and also lost appetite and lost weight. After physical, laboratory, and radiologic examinations, the patient was diagnosed with liver nodules with SCC characteristic with LIRADS 5 and referred to Fatmawati. And the patient has been given the combinations of lenvatinib and 4 tests in almost 1 year. After 4 tests and lenvatinibs, his echo performance is very good. And the good news is in last June, the patients could go to the Mecca for a Hajj. But there are sometimes rash, redness, itching, and peeling of skins on palms and soles, and we need to adjusting dose of his lenvatinib. This is the laboratory examinations. There is a decrease in hemoglobin, slight increase in ALT and AST levels, he also have an high PIVKA score, have high PIVKA levels, not normal IFP levels with hepatitis B and hepatitis C non-reactive. This is the radiologic examinations. After TACE, we can see that the mass was reduced after the TACE and the lenvatinib almost 1 year. This is a patient with single big nodules with CHALPUK-A and good echo performance. From the BCLC, we can classify this patient as the intermediate stage. And the treatment modalities of these patients, usually we treat the patient with TACE. But after hard discussions, when the teams decided to give the patient with combination of TACE and lenvatinib. Why combinations? Because from the journal, we see that the combination of TACE and lenvatinib is have a good overall survival and good progression-free survival than TACE alone. And also the combination of TACE and lenvatinib also has a good profile compared to use of single lenvatinibs. And there is no side effects, no difference in side effects. And in the launch trials, the combination of lenvatinib and TACE has a potential therapy for advanced hepatocellular carcinoma. They are good median overall survival, progression-free survival, and overall objective response rate. So the combination of lenvatinib and TACE could be a potential therapy for advance of HCC with a good performance and good CHALPUK. Recent study shows that this combination has a good tolerability, good overall survival, and progression-free survival. But further studies are needed to determine the best time to initiate its therapy. Unfortunately, after 1.5 years, the patient feels that he has an enlargement of abdominal and there is an AC test. And from the multi-phase abdominal CT scan evaluation, there is an enlargement of his nodules and also has a new nodules, small nodules in the segment 5. So what should we do? Usually we have to change the systemic therapy to immunotherapy, but the price is very high. So the team decided to continue the systemic therapy is lenvatinib. And usually we combine this therapy with the ablation therapy, which is we don't have yet in Fatmawati. I think this is the best to do the ablation therapy in this patient in segment 5. Maybe this is our case. Thank you.
Thank you. Ms. Dr. do you have any comments on this case?
Thank you so much. It's well done with lenvatinib and also TACE. One of the TACE, the side effect is after embolization of tumor feeding the arteries, they make some tumor necrosis factors, and also the vascular endothelial growth factor, VEGF. Yeah, as they can be make some trouble in the liver cancer. That's why the lenvatinib and other like immune therapy can be helpful. This is the main concept of this treatment options. So regarding to continuously going the treatment is can be continued TACE, even that they have no any portal vein thrombus, and we can continue with the transarterial chemoembolization. The only one of contraindication is once the patient have some liver, such as for this lesion has, if they have like anterior and main portal thrombus, we have no more chance to perform TACE. Instead of this, maybe hepatic arterial infusion maybe is better, and I can't suggest this patient as a based on this image. I can't suggest the thermal ablation. But because of its, we have to select like patient who can make a good result. Otherwise, you guys will losing opportunity to using that thermal ablation. Thermal ablation is really helpful can be radical treatment. Alternative is surgery, but tumor size is very important. That's why I don't think it's a good candidate for the thermal ablation. And several times, embolization 4 times important. I can see that the vital uptakes, and then already some AV shunt is already done because of after the CT scan, you guys can see that color change, right? And that's why the full phase contrast enhanced CT scan shows arterial phase, and delayed phase. That's something washout sign, which means they have some still feeding arteries. I think I can suggest for this patient hepatic artery infusion and or like with ETAs, and yeah, they can continue with lenvatinib as well. Yeah, no ablation.
How about the ablation for the small noodle together with the
Yes.
TAC?
Yes, and then the meaning of the ablation is ablate once or twice and completely because of the tumor. This is a kind of radical treatment. If they have some remaining tumor, this is not necessary to that. If you're planning to make a right hepatectomy and in the left side have one tumor, this is a meaningful. Ablate and resect. And after the ablation, no any live must be exist in the liver. That's why alive and tumor, it's if the 70% of the volume is occupied by tumor, you don't need to touch. Even know that.
Okay.
It's still suitable for this diameter,
Yes.
centimeter.
Almost 9 centimeters. Yeah. In our study, and in my study, I performed more than 3,000 cases, and European doctors can cure like around 6 centimeter lesion. They can cure. Survival rate is more than 3 years, 6 centimeter lesion. But in my case, I can say 5 centimeter is nice. In order to just stop the growth of the tumor and to controlling the size is my limitation is 8 or 7 centimeter. It's we can help, but survival rate is not so big, much higher. So size is one thing, but important things is vascularization. Yeah, vascularization. If you see some additional vascularization from supraphrenic artery and also intramammary artery, in order like supplying artery, some additional collaterals, if you detect, please make embolization. Yeah. Size is important, but vascularization is more. If you see that vascularization, please do that.
Okay.
Yeah, this is my suggestion.
So this victim is case and not become not available to ablation. Lymphadenate is
Lymphadenate is okay, but regarding ablation, it's ablation is good for smaller than 4-5 centimeter lesion. Yeah, this is too big. Too big. Yeah. Yeah.
about the resection.
Huh?
What about the resection
The
for
resection regarding the PLT and other things, and we need to check the volumeter. And if you guys using ICG test, we need to check with the in the same green test. If ICG test is not really is if ICG test is okay, maybe we can consider. But before this, we need to consider one thing as resecting liver is if size is it's okay, right? Resect right is a not so big and it's we have to consider. And resection maybe often vein embolization once, and after that, trophy, and we can write about one of the consideration. Okay, thank you.
So thank you. So to summarize, maybe for this case, I think what Professor Iridu suggests is that we continue the lenvatinib and try to do another TACE or hepatic artery infusion. but for the ablation is not recommended because in this case we cannot do full control of the primary lesions, right?
Yes, right.
So if we can do a full control like of hepatic resection for this case, then the small nodule can be ablated as well. But in other situations, the ablation is not suitable.
Yes, right.
Yeah.
This is no, not recommended for this.
Okay. And ada pertanyaan lagi dari audience? Or maybe from the Zoom, any other questions? Dr. Gary, maybe you can type the questions and I will communicate to Professor Iridui. For the meantime, we will continue with the second case, will be presented by Dr. Adrisel. This is our interventional radiologist. Please.
Thank you.
Ready? I'm sorry because the audience is many Indonesian. With presentation with bahasa. Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi para audiens semuanya yang hadir di ruang ini dan di ruang Zoom. Baiklah, ini adalah salah satu case yang saya kerjakan di Rumah Sakit Fatmawati mengenai TAC pada kasus hepatocellular carcinoma. Kita sudah melakukan TAC mungkin sudah lebih dari 5 tahun di Rumah Sakit Fatmawati karena sebelumnya kita TAC selalu ngirim ke RSCM. Baik, slide. Pada kasus ini datang seorang laki-laki 59 tahun datang ke hospital ke rumah sakit dengan nyeri perut dan sitos, didapatkan HbA1c yang positif, kemudian bilirubin 1,9, bilirubin total 1,9, kemudian INR-nya 1,7 dan pasien membawa hasil dari rumah sakit lain dengan hasil koliotasis dan sitos. Kemudian pada pasien ini slide kami lakukan CT scan, kemudian didapatkan gambaran pulsa di segmen 567 hepar kanan dan karakteristik yang arteri, arteri dan wasot pada wasot vena. Kemudian didapatkan juga adanya nodul di daerah segmen 6. Ini nodul kecil kurang dari 2 cm. Di mana ukuran tumor yang besar ini adalah sekitar 7 sampai 8 cm. Next. Ini adalah gambaran fase venanya, didapatkan washout di fase vena pada pasien ini. Kemudian di nodul yang saya sebutkan tadi juga washout. Jadi karakteristik dari pasien ini adalah dari imaging kita mengarah ke hepatocellular carcinoma. Lanjut. Kemudian kami dikonsulkan oleh teman-teman hepato atau internis untuk dilakukan TAC atau tes. Kami menggunakan kateter Yashiro 5 frank, kemudian menggunakan mikrokateter untuk mencari feeding arteri menggunakan ukuran 1,9 frank dengan ukuran wire yang cukup kecil yaitu 0,014 inci. Kemudian kami melakukan conventional test menggunakan lipiodol dan regimen obatnya epirubicin. Dan ini epirubicin mungkin kasus baru 2-3 kasus di rumah sakit kita gunakan epirubicin. Sebelumnya kita menggunakan doxorubicin, tapi karena peraturan pemerintah yang mengharuskan rumah Indonesia itu menggunakan PKDM, jadi doxorubicin powder yang saya butuhkan untuk TAC mungkin bukan hanya buat kami, di seluruh Indonesia sudah di stop dengan doxorubicin powder, sehingga yang tersedia saat ini adalah epirubicin powder. Kelebihan dari epirubicin adalah bersifat tidak kardiotoksik. Lanjut. Ini gambaran dari TAC. Ya, bisa diputar. Ya, ini adalah kita lihat feeding arteri yang cukup turtos di bagian cabang dari arteri hepatika kanan. Kita lihat adanya blasting tumor di situ. Kemudian ini gambaran angiogramnya. Lanjut.
Kemudian kami lakukan TACE menggunakan epirubicin dan lipiodol tadi. Ini adalah gambaran retensi lipiodol yang ada pada angiogram, sehingga setelah TACE didapatkan flow dari vaskularisasinya berkurang ke arah tumor. Lanjut. Nah, ini adalah lengkapan layar dari jika kita setelah TACE di fluoroskopi, maka gambarannya adalah hitam seperti ini. Ini menunjukkan retensi lipiodolnya cukup baik di daerah tumor. Lanjut. Jadi di sini kita TACE adalah salah satu tindakan prosedur di bidang radioimetensi yang mana memberikan kemoterapi dan embolic agent langsung ke target tumor melewati arteri hepatika dengan kateterisasi. Indikasi TACE itu pertama kita lakukan pada kasus hepatoselular karsinoma, kemudian selektif metastasis yang biasanya kita lakukan TACE kalau ada metastasis kolorektal, kemudian kalau karsinoma masih stabil juga dilakukan untuk TACE, kemudian paliatif untuk unresectable lymphoma. Lanjut. Ada beberapa kontraindikasi yang baik itu absolut dan relatif. Jadi kontraindikasi yang absolut itu adalah encephalopati dan adanya tumor yang besar dan tumor metastasis yang terlalu besar maka tidak dilakukan TACE. Kemudian relatif kontraindikasinya adalah trombosis di vena porta. Bagaimana trombosis ini kalau misalkan trombusnya dengan vena porta bisa kita lakukan TACE, tapi kalau misalkan trombus sudah menutupi vena porta dengan vena porta maka kita tidak lakukan TACE karena ini sangat tidak baik buat vaskularisasi tumornya. Kemudian liver dan renal failure juga merupakan salah satu kontraindikasi relatif. Kemudian uncorrectable probability juga merupakan salah satu kontraindikasi relatif. Lanjut. Studi ini dari kasus ini kita dapatkan kita lakukan TACE karena berdasarkan kriteria Barcelona kita lakukan adalah filming BCLC dosis B dengan celpuk A, di mana ukuran tumor yang kita hitung adalah 7,8 cm dan lebih dari 1 kg. Jadi kita lakukan TACE untuk pasien ini. Lanjut. Kami menggunakan epirubicin dan lipiodol itu adalah salah satu TACE di bidang konvensional, di mana epirubicin powder ini kita larutkan ke dalam 3 ml cairan antibiotis. Kemudian kita buat dua seperti solution. Kemudian solution dari epirubicin ini kita campur dengan lipiodol dengan perbandingan 1:3. Dengan penggambaran mekanismenya adalah water in oil, bukan oil in water, tapi water in oil. Jadi sehingga yang kita larutkan pertama adalah epirubicin ini ke dalam lipiodol lebih dulu. Ini hasilnya sangat berbeda kalau misalkan kita lakukan lipiodol ke dalam epirubicin. Ini stepnya adalah seperti ini kurang lebih. Next. Dan perbandingan yang kita lakukan adalah ini yang terbaik 1:1, 1:2, sampai 1:3. Jadi semakin kecil perbandingannya semakin baik. Cuma kalau kita melakukan yang perbandingan mungkin kecil itu bisa ya karena harga lipiodol lumayan. Ini gambaran ketika kami di lab melakukan mixing drugs yang saya sebutkan tadi. Ini adalah konvensional TACE yang menggunakan mixing drug yang kita lakukan selama pemeriksaan. Jadi kita lakukan pencampuran obatnya langsung di dalam lab. Ada informasi tertentu yang sudah dilakukan di bagian kemoterapi. Lanjut. Setelah TACE, kita maka akan lakukan monitoring terhadap liver dan renal function-nya setelah 24-48 jam. Biasanya dokter Niko minta sama saya jangan pulang dulu pasiennya kalau belum 48 jam. Jadi kita monitor di rumah sakit ini selalu 8 jam setelah KC. Kemudian kita juga akan monitor post-KC syndrome, itu biasanya terjadi beberapa keluhan pada pasien, yaitu salah satunya mual muntah, demam, atau nyeri yang tidak nyaman pada abdomennya. Kemudian kita lakukan juga follow up imagingnya itu setelah 4 sampai 5 minggu setelah KC. Jadi biasanya setelah KC kita lakukan follow up imaging, CT scan 3 fase lagi setelah 4 sampai 5 minggu setelah tindakan KC. Ini adalah gambaran, mungkin kalau skematisnya kita lewat KC biasanya di rumah sakit ini masih menggunakan transfemoral artery. Jadi kita melihat ke target organnya seperti ini. Lanjut. Baik, mungkin itu presentasi dari kami dalam salah satu kolaborasi di bidang hepatobiliar tim yang ada di rumah sakit Farmati ini. Saya Dr. Niko dan Dr. Adianto. Terima kasih. Please, if you have question, Prof. Rudy.
Okay, Professor Ridwi, please have some comments on this case.
Yes. Actually, this is really well done. Congratulations, because of it's not easy case, especially that you guys, have you seen that tumor feeding vessels? How like a king, right? As a zigzag. And as most of the right hepatic artery rising from the truncus celiac and goes to the proper and common hepatic arteries, but sometimes kidney goes from the superior mesenteric arteries as well. And but this artery is can be like a first, second, third, fourth branch, come and narrowing. Because I saw you using a 1.7 French, really nice microcatheter and the guiding to the selecting and the very visceral artery. The vascularization was 2 different main arteries. You select first, more difficult one. It's more lower and visceral one. That's nice. Second part is after the injection, the pyruvitine mixture, and after then you find out in other like feeding arteries such as looks so big that the one, right? This one. That the one is the upper part and lower part is here. Actually, it's rising from this. It's not easy to go, and it's good technique. I think you have a good technique. So regarding this case, one thing was really good, suggests your patient selection because of the patient had. First, we need to think about the hepatojejunal anastomosis. If the patient have no hepatojejunal anastomosis, we can perform like this kind of embolization. Otherwise, the patient if have hepatojejunal anastomosis, it's one of the contraindication because of after this kind of big embolization, tumor can be make abscess formation. That's why. So on the other hand, this tumor has no look like a intrahepatic rupture, right? Necrotic zone. If this kind of big, huge infiltrating mass have ruptured part, it's not easy to make good embolization because of once you inject your embolic material can be contained only inside in here. It's useless. That's why is 2 arteries was good feeded and the tumor was well reserved lipidal uptake like peripherally as well. If you're using a bigger embolic material, is your vessels proximal part can be blocked and distal part will not block. And then collateral comes out from another diaphragmal and supraphrenic arteries as well. That's why you made a good deal and that small amount of ascites is okay. And I saw the clinical result, but I haven't seen what albumin and bilirubin was how. In case of like this kind of case, I like to select albumin higher than 30. Bilirubin less than 30 is more safe. But anyhow, it's really good embolization because of we don't embolize normal parenchymal artery. We embolize it like an exact tumor feeding artery. And so we don't need to worry about liver failure. That's good. And it's unfortunately this tumor is too big and also well well encapsulated. If this is like a well encapsulated lesion, it become a really good outcome. So that after this, do you have like a follow-up CT scan after embolization? Mhm. I see. So important things is ablation and embolization, both one same thing is follow-up, must be contrasting has a CT scan after, yeah. And is angiographically, it's really well embolized feeding arteries, but few months later, we'll have to check contrasting has CT scan with alpha-beta protein. That's the really good follow-up. And I can see this is a procedure well done. I hope this tumor can be controlled and not more growth can be almost 1 more year, I guess. So the regarding ablation method, it's too peripheral and no safety margin and too bigger. That's why I still can't suggest. Ablation. Yeah, yes. Ablation can be performed if this lesion, wait, so let me explain one thing. So this lesion is 100% controlled if this one is okay. But regarding this lesion is not easy to make an embolization, maybe we can make ablation. But it's how it look like on ultrasound, depends on this. For example, let me explain to you. The puncture side is really important. Most of the puncture side from intercostal approach to here, this is too close to the diaphragm. You see that the one is diaphragm. This. Yeah, it's not easy because of you see that this is a suprarenal gland here. The patient, when deep breathing, lung will come here and make a space. It's not easy. Yeah. Instead of this, if patient have some ascites, use it. Yes. The patient originally he have some ascites, right? And also it's how it look like an ultrasound. Why I'm asking? Because of once you make embolization here, it's full of white and make acoustic shadow with this. It's not easy to find out, okay? Then maybe you guys can use CT guidance. And on the other hand, puncture, if you make a puncture from this side, you have to make 2 puncture or use multi-step mode to more spheric ablation, more spheric. Otherwise, most of the brains make like oval shape ablation, like this, like an egg, oval shape, like this. If you use a multi-mode step and you use microwave system, then it's gonna be like spherical ablation. But think about that, like safety margin, it's too close to the diaphragm. That's why please add some more water and make more ascites, and then you can make an ablate from CT guidance, maybe from that side. But please, careful, this is a diaphragm and lung as well. Yeah, thank you.
So do you think the ablation should be done before or after the TAC? And how many time period should we wait until the TAC? Or can we do it in one session altogether?
Yeah, nice question. Please ablate, please make embolization first. Because of who knows, during the embolization, if we can, for example, you look and see, this is arterial phase. This is hypervascular. Yeah, right? That's why we have a high chance to make good embolization for this. And if without this, segment 6, no any tumor, only these tumors exist, maybe we can perform nicely embolization, and then right after this, same day, right after procedure, maybe we can perform ablation is here. Yeah, combination. That's gonna be good too.
Thank you. So combination treatment is can be done in this kind of case, and patient selections is very important, and we are very fortunate that we have a good collaboration all together in this hospital. Like Dr. Adrisel has performed something that Dr. Idui has also recognized as a good procedure. So any other questions from the audience? Okay, it's been a very wonderful discussion, and we would like to give a round of applause to all of the speaker. And please stay in the front. We have one more presentation from Ibu. Sorry, from PT Murti Indah Sentosa, Ibu Irma will give some presentation first before we end this session.
Baik, Assalamualaikum warahmatullahi wabarakatuh. Selamat siang dan salam sejahtera untuk semuanya. Perkenalkan, nama saya Irma Ferawati dari PT Murti Indah Sentosa, di mana PT Murti Indah Sentosa ini sudah menjadi sole agent tunggal atau distributor tunggal untuk Toshiba Medical System. Mungkin sebelumnya sudah dikenal dan sekarang sudah berganti nama menjadi Canon Medical System. Hal ini dengan waktu yang sangat singkat, saya coba akan mempresentasikan alat USG kami yang kemarin saat akta dan apasal di Bali digunakan oleh Prof. Suichiro Shina dari Jepang bersama Prof. Rinogani dan juga Dr. Kemal untuk melakukan ablasi liver. Baik, sambil menunggu screen. Mungkin saya akan perkenalkan kalau di Murti Indah Sentosa yang kantornya itu ada di Jalan Arteri Pondok Indah. Kita merupakan sole agent tunggal sudah bergerak 42 tahun di bidang alat-alat kesehatan. Kita memiliki X-ray, USG, CT scan, MRI dari Canon Medical System dan juga alat-alat imaging radiologi lainnya beserta critical care dan juga radioterapi yaitu variannya. Baik, kita sudah tersertifikasi dan dari Kemenkes dengan CDAKB. Jadi untuk alat-alat kita sudah e-katalog untuk semuanya. Ini merupakan beberapa produk Canon Medical System yang saat ini sudah berkembang di Indonesia juga, sudah ada di seluruh rumah sakit Indonesia. Baik, secara singkat saja, mungkin karena topiknya ini adalah ultrasound, maka saya akan mengenalkan tipe-tipe USG yang ada di katalog, dimulai dari yang tipe middle ada Aplio Flex, high-end Aplio A450 dan A550, beserta seri premium yang kami bawa di sebelah kiri nanti, yang bisa dicoba oleh para dokter sekalian adalah Aplio E-Series, yaitu I700, I800, dan I900. Baik, sudah bekerja sama dengan berbagai klub Liga Dunia sebagai global sport partnership dengan Real Madrid, Manchester United, dan juga San Antonio Hotspur. Lalu mungkin saya akan skip aja bahwa alat kami yang sangat menunjang untuk liver disease memiliki liver package, khususnya sudah ada di katalog, dimulai dari shear wave elastography, lalu ada attenuation imaging yang berhubungan dengan steatosis, juga ada syrup dispersion untuk viscosity.
Untuk reportnya, kita memiliki kelebihan dengan kompetitor lain, yaitu kita memiliki multi parametric report, di mana di sini kita bisa integrate seluruh pengukuran dari dokter lakukan melalui software-software yang tadi serta hasil lab, sehingga dokter dapat dengan cepat untuk melakukan diagnosa secara akurat. Nah, ini memiliki super microvascular imaging yang mungkin nanti dapat dicoba juga ya dok di alat USG-nya. Kelebihan kita untuk Smart Fusion itu sendiri, kita dapat mendownload data CT scan, MRI, ataupun PET scan dari berbagai modality, tidak harus merek yang sama ya dok. Jadi alat-alat hasil pasien dari hasil CT scan, MRI, bisa kita loading datanya di USG kita, lalu akan disinkronize secara simultan melalui USG kita. Selain Smart Fusion, kita juga dilengkapi oleh Contrast Harmonic Imaging. Kemarin pun dicoba saat workshop di Bali. Jadi USG kita sangat memudahkan untuk liver ablasi karena dari mulai resolusinya yang premium dan juga ditunjang dengan beberapa high-end advanced software yang ada di alat USG. Nah, ini beberapa prop yang disupport oleh alat USG kami untuk seluruh pemeriksaan. Bisa display videonya. Ini contoh untuk abdomen fusion menggunakan SMI dan yang sebelah kanan merupakan prostat fusion ya. Contrast harmonic imaging. Boleh di-play videonya. Ini saat kemarin kita melakukan liver ablasi dengan pasien yang memiliki tumor yang besar dan agak dekat ke kapsul liver. Mungkin nanti hasilnya terdapat di kami. Kemarin kami telah menyelesaikan 2 kasus untuk liver ablasi menggunakan microwave dari RF. Jadi sangat mudah sekali dengan menggunakan microwave RF itu jadi lebih cepat lagi ya dok waktunya dan suhunya bisa lebih tinggi. Baik, mungkin sekian presentasi dari kami. Untuk lebih banyak pertanyaan mungkin boleh ditanyakan saat nanti kita hands-on menggunakan alat. Terima kasih. Wassalamualaikum warahmatullahi wabarakatuh.
Terima kasih atas presentasinya, mudah-mudahan bermanfaat. Saat ini kita sudah sampai pada akhir dari acara seminarnya. Setelah ini nanti teman-teman sekalian bisa ke stasiun-stasiun yang ada untuk melihat penggunaan dari alat ultrasonografi maupun alat microwave ablation. So we have come to the end of the session. Thank you very much, Professor Iridwi, Dr. Nico, and Dr. Adrisel. We hope that this will be the first among many of our encounters, and we will be very happy to come to your place and study more with you. Thank you, and we would like to have Dr. Mursid to present the plaque for Dr. Iridwi.
Thank you. I would like to say only one thing. So that's recently that introduced about the probe, ultrasound probe. Actually, if you guys like first using like ultrasound guided puncture, that's they have some needle guide is really important. As you see that the PTBD is also ultrasound guidance puncture to the small biliary duct, right? Yeah, if you find out like puncture this small bile duct, you can make ablation. Same technique. It's totally same puncture. If you see the small lesion, if you see that cancer, you can make a puncture. Yeah. And if you have not free-handed technique, please use that ultrasound with the guidance. Yeah. Yes, yes. Needle, yes, guide. Yes, yes. Okay. And make always puncture near, just near that, beside of that ultrasound probe. Okay. Thank you.
Thank you very much. Please, Mr. Musi. Thank you very much, everyone.
Your doctors will visit my hospital and also I can come here to work for those celebrations. We can have many patients. Yeah, every day many patients will.
Silahkan bagi para peserta untuk menuju station sambil nanti makan siangnya juga disiapkan. Untuk teman-teman di Zoom, terima kasih atas partisipasinya. Acara ini saya tutup.
Baik, Ibu sekalian, adik-adik dari koas, mohon berkenan untuk mengisi evaluasi yang ada di depan, dan juga untuk Bapak Ibu sekalian untuk mengisi daftar hadir, karena daftar hadir itu nanti akan digunakan datanya untuk input di LMS, ya untuk pengurusan SKP ya, gitu. Oke, baik. Terima kasih. Oke, sekali lagi saya ingatkan bagi Bapak dan Ibu sekalian, dokter yang atau peserta yang ada hadir di sini yang membutuhkan SKP, dimohon untuk mengisi daftar hadir yang tadi saya share di depan. Belum ya? Belum, nanti saya akan share untuk sementara evaluasi dulu. Karena kalau nggak ngisi daftar hadir, maka saya tidak punya bukti kehadiran Bapak dan Ibu sekalian pada kegiatan hari ini. Untuk sementara 10 menit saya tunggu untuk mengisi evaluasi, baru saya akan tampilkan untuk link daftar hadir. Terima kasih. Ya, berikut adalah barcode untuk daftar hadir. Sekali lagi, jika ada yang LMS-nya ingin SKP, ya dipersilakan untuk daftar hadir diisi, karena kalau nggak mengisi daftar hadir, saya sekali lagi tidak punya alasan untuk memasukkan atau menginput nama Bapak dan Ibu ke dalam LMS kami. Mohon untuk dipastikan tiga hal. Pertama nama, kedua email, yang ketiga adalah NIK-nya. Di sini saya menggunakan NIK ya, bukan NIK. Saya menggunakan NIK atau nomor KTP. Terima kasih. Masuk juga kepada para peserta yang ada di Zoom, mohon berkenan untuk mengisi link absen, kemudian evaluasi yang telah saya sematkan di kolom percakapan. Baik. Nanti untuk link apa namanya nih? Link bukan link ya. Alamat email ini lebih baik di input di apa namanya daftar hadir aja ya. Karena nanti data yang saya gunakan adalah data yang ada di daftar hadir, bukan yang ada di sini. Ini sebagai catatan aja sih. Kalau untuk yang akan saya input ke LMS adalah yang pada daftar hadir. Oke. Jadi tidak perlu untuk, ya boleh sih isi teman, nggak usah lah ya. Baik, Bapak dan Ibu sekalian, peserta Zoom, mohon izin saya akan end meeting for all. Jika nanti ada yang ingin menyaksikan tayangan ulang, silakan buka YouTube yang sudah saya sematkan di kolom percakapan. Oke, saya silakan untuk dicatat link YouTube-nya. Pada pukul 11.22 akan saya end meeting for all. Dan sekali lagi mohon berkenan untuk mengisi daftar hadir dan mengisi evaluasi yang sudah saya sematkan sebelumnya.